Jessica, when you look at therapeutic outcomes, first for anti-TNF, what's the expected response? I mean, even just practically, what do you tell your patient in the clinic about therapeutic outcomes with anti-TNFs? And then I do want to touch on ustekinumab, especially some of the data and quality of life, and probably ask Bill for some of his input on those as well. So what are your outcomes for anti-TNFs? When you start somebody, what do you look for? You kind of mentioned before, but get into that a little bit now.
Sure. So when I'm discussing with a patient and we're making a decision about, which therapy to start, if we're starting with an anti-TNF, I will use infliximab as an example here. One of the things we've been alluding to is really the speed of action of that medication. And so I discuss with patients, especially if this is their first biologic, we really do expect that by the end of induction, we want them to be feeling better. And if you look at the original clinical trials, Act 1 and Act 2, about 64% of patients had a clinical response by the end of induction, and about 35% or so of patients were in remission. And so again, I'm really following patients closely around that week 14 mark to see, are we hitting some of those targets, and then making adjustments if need be, because you may need to optimize your dose escalate. But I do also always talk to my patients up front before I start any therapy. When we're going through risks and benefits, I say, one of the biggest risks is that this drug is just not going to work for you. And so we have to prepare for that and be on top of that, so that if you are a primary non-responder, for example, we move on quickly and we don't sort of delay getting you on appropriate therapy. So I do discuss that up front as well.
Good. And then, so Bill, ustekinumab's the newest biologic or monoclonal antibody that we have for Crohn's. And then in a minute, I'm going to ask David about UC. But tell me a little bit about vedolizumab and ustekinumab for Crohn's disease, also with some of the data on quality of life.
Well, I think in terms of the active disease, you've got two groups of patients. You have patients who are naive to TNF blockers, and the data that Jessica was just talking about really applies to anti-TNF naive patients. So you would expect about a 60% response rate by clinical measures in naive patients. It's lower if you're having your second anti-TNF. And so for ustekinumab, when the clinical trials were performed in Crohn's disease, there were two different patient populations that were studied in separate clinical trials. In the anti-TNF naive patients, the response in Crohn's disease was also about 60%. So very similar to what you would expect to see with infliximab or adalimumab. And what differentiates it in my mind is that you don't have black box warnings, and you have the large intravenous load that you sort of like with infliximab, and then you have every 8 weeks sub-Q dosing for maintenance, which is sort of like adalimumab but much less frequent. So that stuff all fits together nicely and impacts, I think, adherence and compliance and patient acceptance, and it's part of the spectrum of quality of life. For vedolizumab, the effects in anti-TNF experienced patients were less profound. And in fact, in the pivotal clinical trials, there were several trials that looked in subgroups of patients at anti-TNF failure and didn't see a significant induction effect. Now, as you get into the maintenance, you can eventually see a benefit for vedolizumab in maintenance. But, I think in the failure patients, it's probably just not quite as potent. It's quite safe, and there'll be patients where it works. The ustekinumab effect is probably stronger. And coming back to ustekinumab, then let me back up. In the naive patients, there are patients who will respond to vedolizumab. There's a clinical prediction tool that helps pick those out. And there's actually an evolving clinical prediction tool for who's going to respond to ustekinumab as well. So I think these clinical prediction tools will have a larger role in our practice in the years to come. But even without selected patients, you get a good effect in naive patients. And then in the failure patients, you see a nice effect as well with ustekinumab for induction and maintenance. And, the quality of life tracks very heavily to clinical response and remission. So if you have, and you actually get the most bang for the buck in the response, So when you take moderate to severe Crohn's or ulcerative colitis, they have pretty terrible quality of life. If you put it in a generic health-related quality of life assessment like SF-36, it looks sort of like class 3 or 4 congestive heart failure or chronic renal failure with hemodialysis. I mean, it's shockingly bad. And then when you get a response, you get up to just below population means for health-related quality of life. So you get most of the rise with the response. And then if you get into remission, amazingly, the health-related quality of life actually exceeds the population means around the world. So quality of life just heavily tracks to having clinical improvement or response.
Yeah, and I think, you alluded to, both you and Jessica, the Bruce Sands study in 2018 that looked at ustekinumab and improvements in quality of life. And again, I think as we talked about earlier, the quality of life impact on IBD, the class 3, 4 heart failure. I mean, again, these are some very poor quality of life. So it's interesting how we look at treat to target, but we also take into account the quality of life.